Where's the music? Okay. Hi, my name is Brian LaPayower, and this is LaPayower Report, the fundamental talk show program where I conduct conversations with individuals who have unique skills and talents. Did you know that cardiology is a medical specialty dealing with disorders of the heart, especially the human heart? The field includes diagnosis and treatment of congenital heart defects, coronary artery disease, heart failure, valvular heart disease, and electrophysiology. Physicians who specialize in this field of medicine are called cardiologists. Cardiologists should not be confused with cardiac surgeons, cardiothoracic, and cardiovascular, who are surgeons who perform cardiac surgery via sternotomy, open operative procedures on the heart and great vessels. As the center focus of cardiology, the heart has numerous anatomical features such as arteria, ventricles, heart valves, and numerous physical psychology, which features subtle heart sounds afterload that are of concern. Disorders of the heart lead to heart disease and cardiovascular disease, and they lead to a significant number of deaths. One of them, which is cardiovascular disease, is the leading cause of death and caused 29.34% of all deaths back in 2002. My featured guest for this program is within the field of cardiology and also in the field of medicine involved in the surgical treatment of diseases affected organs inside the thorax, which is another name for the chest. And his name is Dr. Vijay Singh. Dr. Singh, welcome to the program.
Thank you. Thank you, Brian. Thanks for
now,
having
can you tell me more about your, I do understand, I went like moments ago, we talked, and you actually are a, I know I mentioned about cardiology, but you're not into cardiology, am I correct?
Right. Yeah, I'm a cardiothoracic surgeon, which you mentioned earlier as well. The difference is what you highlighted before. We actually perform surgery on the heart and the lungs.
Okay. So basically, you, if I'm looking correctly, I did actually make some like printouts of the procedures. So you do, it does involve with medicine, but it also involves into surgical equipment with affecting the diseases.
Right. Cardiac pathology or disease, as you stated, caused about 29% of all deaths in the U.S. in 2002. That's even higher now. It's about to 40%. So it beats cancer in terms of what causes death in the United States. And what we're here to do is promote, I work at Staten Island University Hospital. We're doing some innovative procedures dealing with the heart and lung.
Okay. And how long have you been at Staten Island University Hospital?
I recently joined, but I've been in the North Shore LIJ system for the last 2-3 years.
Okay.
Yeah.
And the field itself, how long have you been in this field for?
About 4 years.
4 years,
Yeah.
okay. Tell me more about, now I do understand that usually for this cardiac thoracic surgery, they actually do open up the body. Is that something that you also do that too?
Yeah, the standard way that the procedure has been done is called a sternotomy, which is basically outlining an incision right in the middle of your chest. That's how heart surgery has been done for the last 70, 80 years. We're doing something a little different now. We're doing what they call minimally invasive heart surgery.
Can you explain me about that?
Sure.
As well as the rest of the viewers who are watching?
So in terms of heart surgery, what do? We deal with valvular problems, and we deal with coronary artery bypass surgery.
Okay.
And both those entities were usually dealt with, and even till this day is dealt with as sternotomy. There's inherent problems with that. People take a long time to recover. There's a higher incidence of infection, and there's a lot of pain. We're doing minimally invasive, where we're making small incisions on the side and going in and doing the same surgery, not changing anything, having good outcomes, not even better outcomes, and having patients leave the hospital early, having less chance of infection, and having less pain.
Okay, now as far as surgery goes, how many hours does it take for surgery on
Well, depending on what the problem is with the patient, usually anywhere from 2 to 4 hours.
2 to 4 hours.
Right.
Okay. And for recovery time, you said it's like less than the actual amount?
Yeah, usually across the country when you do a sternotomy, people stay for about 7, 8 days. We're usually discharging our patients within 4 to 5 days, so there is a difference in terms of recovery.
Okay. Now, let me ask this question. How do you keep your heart healthy?
How do you keep from preventing to see us is you have a good diet and you exercise. That's the first way, and don't smoke. Smoking is a bad problem that a lot of people have, and you smoke, you're going to end up having something done eventually.
Okay, well, I'm not a smoker, though, but my father was a smoker.
Right.
He's actually long passed away. He died back in June 3rd of 2005. And he, about nearly within like a long time of his life, but he actually stopped about 20 years before 20 years before his death.
Right.
And he did have some like surgery involving the heart. He had water flowing into the heart.
Right, right. Yeah, it's a bad problem. Smoking eventually gets each person that does smoking eventually will get you one way or the other. So it's again a bad problem, but we can fix it, and we can turn the clock back, and that's what we try to do with our surgery. So if you've done something bad to your body or your heart, we can do things in an innovative way, and that can turn the clock back. And you don't have to go to Manhattan to get this done. You can do it right here in Staten Island.
Okay.
And that's what we're here to promote.
Now, I do understand there also are other procedures involving the heart as well, too. There's also, I mean, besides cardiac surgery, okay, and it's also, let me see if I have the other paper.
We do thoracic surgery, too, which is involving the lung, like you stated in the beginning. It's dealing with the chest.
Yes.
Along those lines, people who do smoke have a high incidence of lung cancer, so we can go and take out those areas and deal with them.
Right, but the main three is actually cardiac, cardiothoracic, and of course thoracic surgery.
Right, they fall in the same guise, but that's correct.
Okay, so there's no difference between the three of them.
Right, they're one and the same. Basically, I am a cardiothoracic surgeon. I can operate on the heart and the lung, and usually people in this field can do all.
Okay.
So,
Okay. I do believe we have a presentation, though. A presentation. I don't know if we get it on the screen when it comes to chance about the explanations about
Sure.
procedures, if I am correct.
Yes.
Okay. I don't know if we have that. Okay, here we are.
Okay.
Maybe you could like talk about it
Right,
from
that's
here.
me. I'm from Staten Island University Hospital, which is part of the North Shore Long Island Jewish system. It's a big health system. It has 15 hospitals, and Staten Island is one of them. We can go to the next slide.
Okay. They're gonna like take the time, like changing it over. You
Okay.
could change over as it is, Yeah, just to make a control room. They could like change the things as is. Just do that. They know? Okay. That's get ready.
Okay. So expounding on that, again, the whole point is to make the show for me is to promote the fact that you don't have to go far away to get innovative procedures done if you have some kind of pathology. It's always been thought that there's nothing available here in Staten Island, but Staten Island University Hospital has had a heart program for the last 10 years. Joe McGinn, who's my immediate boss, is the founder of the program. And he's really the founder of all these innovative techniques, and we are able to provide that. We want to let people of Staten Island know that they have an institution that is leading
Okay, we have
edge.
another thing on the screen right now.
Yeah, so this is just a little about myself. This is my current position where I trained, which was at North Shore Long Island Jewish, and then a little about my residency, which was in Baltimore.
You also went to a Hofstra.
Well, Hofstra is actually joined with North Shore LIJ, and
Okay.
it's one health system now. And then Hofstra actually has a medical school which started this September, which is one of the newest allopathic medical schools in the country.
Okay, and I do know that Hofstra University is actually just about the edge of Uniondale.
Yes,
around.
yeah, right, exactly. So, and I trained in Maryland for general surgery, and that's pretty much it. And in terms of if we have some of the other pictures up, I'll
Okay.
expound on what we're actually doing, and you can visually see the difference between a sternotomy and a incision that occurs on the side.
Okay.
There are many advantages.
Okay, and how many years did it take for you to get up to actually ordain to become a doctor?
It takes a while. It takes 4 years of medical school, and then you do residency training, which is anywhere from 5 to 7 years. So you do the math; it's about 10, 11 years it can take up
Okay,
to.
now I see everything of your goals now.
Well, this is the goals of the show. Essentially, was for me to come on and just to,
Yes.
as I stated before, illustrate or at least demonstrate to the people who are watching that we do some pretty innovative, cutting-edge procedures here on this island, and it's something to be proud of. I think with where our hospital that represents this borough of New York is doing things that most people across the U.S. don't have access to.
Okay.
So I think I'm pretty excited about it, and I want to at least let people know about it.
Okay. Now, normally, how many patients do you usually get a day? About?
Well, we do, in terms of yearly, we do maybe about 1 or 2 cases in heart surgery a day. So we do about anywhere from 400 to 500 cases a year. That's just heart surgery. Now, lung surgery, you add another 300 to 400 cases. So we're fairly busy, and our goal is to also expand out to, besides just Staten Island, into Brooklyn, into Manhattan, and just increase our exposure, because we think we're doing some nice stuff out here.
Okay. Okay. Let's see.
So here's actually a good picture.
Okay.
This is what a standard sternotomy is.
Right.
You see on the left there, patient who's had a procedure. It's a scar right down the middle, and on the right, it's showing how we actually see the heart. We put a little retractor in there, and we get the heart, and it's actually the heart sits right in the middle of your chest. And it's not in the left side; it's right in the middle of your chest. Exactly how it's demonstrated here. As we will proceed, you're going to see pictures that will show the difference between a sternotomy and what we're doing, which is minimally invasive surgery, where the incision is not in the middle of the chest, not a big incision, it's actually on the side. And it's a small incision, but we're doing the same procedure and having excellent results, and people are having much better outcomes with it.
Now, let's say during any of those surgeries, after the patient's all healed up, they're resting, if they experience any problems, what would you do then?
Well, we're actually very aggressive in watching our patients.
Okay, well, now we do have another picture.
Okay.
Could you picture on there, please?
Sure. This is a minimally invasive procedure. This is a small incision going through the left side of the chest, right beneath the nipple in men.
Okay.
And this is how we do actually our bypasses. We go right there, and it gives us excellent access right to the heart, and then we're able to do our bypass surgery just through that small little incision.
Okay, that's actually done through the center or actually
That
on the
one
side?
actually, that picture is demonstrating what we do, which is not in the center, which is actually on the side.
On the side?
Right. It's a small incision. It's probably about 4 to 5 centimeters, and you can get the same results doing this with 4 or 5 centimeters versus this about 12, 14 centimeter incision. It's definitely a little more difficult, but I mean, we've done this for a while, and we've done pretty well with them.
Okay.
And to further go on that question you asked in terms of what we do with our patients, we follow our patients, at least we see them 4 or 5 times within the first month after they leave the hospital.
Okay, now we do have another image right here.
So this picture just kind of again demonstrates the difference between the standard sternotomy and the minimally invasive. You'll see incision right in the middle versus the ones on the side. Kind of just further showing the difference on a model And as you'll see as we go along, you'll see some more pictures showing the difference.
Okay.
Again, getting back to the patient care, which I think is very important. What we do with patients is when they get discharged, we actually have people come to their house.
Oh, yeah?
After the second day that they're home and after the fifth day they're home. So we're really on top of if anything goes wrong, we're ready to deal with them. It's serious business. You know, heart surgery. It's not for the faint of heart. So you have to patient care is a big part of actually having good results, and I think we do that pretty well.
Okay. Now, another thing about the heart, I mean, if someone was, let's say someone was having trouble with the heart.
Right.
In other words, what about an enlarged heart? Okay, we do have another picture.
Okay, this is actually a pretty good picture of how we do our bypass. If you remember a couple of slides ago, we made a small incision through the chest, and we have a little special instrument that we open up that little area, and you actually can see the heart pretty well from that incision. And we have some other little gadgets that we use to enable us to really visualize the heart.
What kind of gadgets, actually?
Well, they're little gadgets that we use to move the heart around a little, because you are in a smaller hole in a different angle. So we need a little help in terms of getting the heart in our face. And it's a little detailed getting into exactly what the gadgets are, but essentially what they do is they just help move the heart right into our field. So we're not using long instruments. We're using the same instruments as we would if we did a stenotomy, and this way patients are not suffering.
Okay, okay. I just wanted to actually, like viewers, just to make aware, my name is Brian LaPayower, and the program you're watching is called the LaPayower Report. My featured guest is Dr. Vijay Singh. He's a medical he's actually a cardiothoracic surgeon at Staten Island University Hospital. And now topic of the subject is called Your Healthy Heart. Okay? Just making viewers aware. I just want to also point out here, I'm usually in the what you call small studio, so for the first time actually in this big studio right here. Okay, now
It's another
I
picture
believe we have
coming
another
up.
picture.
So this is actually a patient, what it looks like after they're done. This is actually, I think, an 84-year-old gentleman that we did a mitral valve, they call, and we're actually on the other side. We're on the right side, which gives us a better view. But you can see it's definitely a different incision versus a incision right through the center of your chest. People do tolerate this better, especially older, elderly patients that have sometimes difficulty recovering from a major incision through the middle of the chest. This is something that they can heal with and actually do pretty well with.
And you said the patient was about 85 years old?
Yes.
So it basically doesn't matter with any age.
No, our age group in heart surgery, our mean age is usually 70s.
Yeah?
Yeah, that's when, after time, the pathology grows, and then you get to a point where your heart can't function. And usually that's when we find things and they come to us, and that's when we operate.
What about anybody that has a pacemaker? Because there are people out there that have pacemakers.
Right. No, we have no problems. We actually put in pacemakers, so we know how to deal with them, and really doesn't really make a difference to us. Actually helps us eventually.
Because there are like people out there that have pacemakers, like Jerry Lewis. He has a pacemaker.
Yeah, there's a lot of people that have pacemakers. Pacemakers is usually a result of people having disease, maybe diagnosed or not diagnosed. Eventually, your heart fails, and you need a little help, and that's what a pacemaker is. So heart disease is a problem in the U.S., probably the biggest problem we have with our diet and our lack of exercise and smoking, as I stated before, catches up with you. And then we have ways to deal with it and help people turn the clock back.
Was there ever a time that you had a patient and the patient, like after making all the procedures, around the heart, there was something still not right?
Yeah, it happens. Unfortunately, and no matter how good you are, you're going to have some things that don't go well. And we're not to say that we never have any problems. Everyone does. If you're doing enough procedures, you're going to have problems.
Like a buildup of plaque in the heart?
Build a plaque, some other stuff. Yeah, you can have a heart attack even after surgery. Patients can die, and that's everywhere. But we do limit that as much as we can. And as I stated before, our results, even with this small incision, match the New York State statistics, and we actually even exceed it. Where the yearly mortality rate is 2%, we get to a 1.3%. We'd like to get to 0, but that's always not possible.
Okay. Now, what about if a patient now usually does it really matter with the side?
Actually,
okay.
we have another picture
Okay.
as we go along. This is the same incision as that old elderly gentleman had. It's through a right thoracotomy, they call, a small mini thoracotomy, and there's an incision on the right side. And that we do the mitral valve, which is one of the 4 valves we have in our heart. That's how we get access to it. And this is basically a schematic of what that other patient, the patient that we just saw before, had. And it's a good procedure. It's actually we actually see that valve pretty well with that incision versus the standard sternotomy.
What if the patient has an enlarged heart?
Many of our patients do. After you do this for a while, you get used to that, and it doesn't really factor into us.
Okay. Is there like, for me, I'm like 33 years old. I'm like, I don't actually, not really actually supposed to be this. I'm supposed to be at least a certain weight of like a normal 33-year-old.
Right.
I'm like weighed about. I'm gonna be truthful. I'm about around 240. So I would probably have a bit of a large heart.
You probably, I don't think your heart is going to be that big. You know, being overweight in general, you have more apt of having disease, maybe high cholesterol and whatnot, and that can lead you to have heart problems. But I don't think you would have an enlarged heart.
Okay, now we do have it.
So these are outlining the benefits of doing a minimally invasive approach. There's less pain, there's lower risk of wound infection, fewer restrictions, faster recovery, and improved cosmetic outcomes. So the things that highlight for me is you don't have that much of risk of wound infection, and people recover quickly. So someone who is dependent on work, that can't be out for a month or 2, they can get this procedure done and conceivably be back to work in a week or 2 weeks, which is, for a person who needs their job, is a big deal. Okay. And that's one of the selling points, I believe, of the minimally invasive procedure. One of the biggest ones in my view.
Okay. Now, I know it said fewer restrictions. What do you mean by fewer restrictions?
Well, restrictions, after you do a major incision, you can't drive, you can't pick up heavy objects. So people in construction, they're pretty much laid out for about 2 months. But when you do incision on the side, you're not putting that much tension in the middle, and you're not that restricted in terms of lifting heavy weights or doing your own work.
So what if you had the surgery done?
Yes.
You recovered, and you're living in a single household. You're the only single person. You have to get out there and drive on your own. Or if you can't, since you can't drive, what about going on a bus?
You can go on a bus. For the first week or so, we recommend you don't drive, just because you do have some narcotics on board, just for some pain issues. So that's the safe thing, is don't drive. So we usually try to find their social aspect. Who's helping them? There's always someone to help around. So we cover that before we do surgery.
Okay. Let me think about something.
But actually that's a good point, because it's not only important to know how to just operate on someone. It's understanding the patient, understanding their living arrangements, how they're going to do after surgery, and that's how you limit problems after surgery, which can be a lot. But if you are anticipating them before you do anything, you can head them off, and patients can do well.
Okay. So basically, after their procedure, there's like less setbacks. No, but they still can't. But what about if they're given any medication?
Yeah, I mean, we have them on some medications. Basically, what you can only do is try to prevent major setbacks, and the only way to do that is be vigilant about things and anticipate things that can happen. And after you do this for a while, you know what to look for, and that's why we see patients about 5 to 6 times in that first month, which is critical.
Okay. Okay. So once surgery's good. Right. They're recovering, and they should go back to their normal lives.
Right. That's the goal. And we want to get them not only to how they were before the surgery, but better. If we can't do that, then there's no point doing the surgery. That's what we tell our patients. So we're going to get you through the surgery, and we want you to be better than you were before, because that's the whole point.
Okay.
So if you're debilitated after the surgery, we're not doing a good job. And the minimally invasive procedure gives us a better chance at having people bounce back quicker and assimilate their normal life much faster than doing a standard procedure that's done across the U.S.
Okay. And what about if anybody wants to visit at least get their heart checked out?
Well, I have my website is vsinghearthealth@yahoo.com. You can always email us, or you can even call the Staten Island University Hospital and ask for the Heart Center, which is 718-226-6210. And if they have any questions or just want to know how to go about finding out if they have any problems, we can help them. And so we're always ready to help, even if you have no heart problems, but you don't know how to approach it. Call us, and we can definitely help in terms of at least getting you in the right hands and moving on.
Okay. Well, actually, our time's actually basically close to the end, though.
Okay.
But I definitely learned a lot about the procedure and the surgery. Can you explain to the viewers out there, if they want to actually get a hold of you, is there a way they can do that?
Right. Like I said, you can email me at vsinghearthealth@yahoo.com, or you can call our main service, which is 718-226-6210, and and you can ask for myself or anyone in the heart services, and just say why you're calling. You have issues, or what do you need from us?
Okay, we're going to take it there. I just want to thank you, Dr. Vijay Singh, for coming on the program.
Thank you.
I do also like to thank the staff and crew here for helping me out. I'd like to thank Christine, Lewis, Davey. I also like to thank Pat Brady. I also like to thank Rialana, Guy, and the rest of the staff crew here at the studio. I also like to special thanks to Master Yusuf Ali Abdullah for helping me out get the guests here on the show. So I'm going to take it from here on the third camera. Once again, my name is Brian LaPayower, and this was LaPayower Report. Take care. Bye.
Great.
Okay.
Thank you.
Thank
Thanks a lot.
you.
Appreciate it.